Hi everybody, this is Professor Richard Riley from the University of Birmingham in the UK, and it's a pleasure to be able to speak to you today about clinical prediction model research, and in particular some of the key steps and common pitfalls that the field currently faces, and also talking about some areas of personal research interest to me. Now, I really like this quote by Galen in the 2nd century. Patient trust was essential in the healing process. It could be won by a punctilious bedside manner, by meticulous explanation, and by mastery of prognosis, an art demanding experience, observation, and logic. So all these years on, have we mastered prognosis and prediction? I don't think we have, and I'm going to explain some of the reasons why in the coming slides. So part 1, an introduction to the field. Before moving on to specifically talk about prediction models, I want to frame all of this talk in relation to the progress framework. Now, the progress group, which I initiated alongside Harry Hemingway and Doug Altman about 2010, we brought together experts in prognosis and prediction to come up with this framework of 4 themes which move from overall average prognosis at the population level to more personalised, individualised risk prediction and prediction of treatment effect. And these were published in 4 articles in the BMJ and PLOS Medicine. And I think it provides a really helpful structure for people who are doing prognosis research to try and understand where their research fits. Because at the moment there's a lot of inconsistencies and a lot of confusion about whether some people are developing models or looking at prognostic factors or confusing absolute risk with prediction of treatment effects and things like that. So just an example, the first progress 1, is overall prognosis. So this is looking at the average prognosis in individuals with a particular condition. So here in breast cancer we have 5-year survival for lots of different countries, and you can see that Iceland are doing the best with about nearly 95% prognosis, and the Czech Republic have down to about 70% are alive at 5 years. Now there's lots of reasons why there could be differences, of course, across countries, but this is just looking at the overall prognosis of breast cancer patients in those different populations. But at the individual level, it's not particularly helpful, is it, to know overall prognosis when we really would like to know our own prognosis. And to get to that point, we need to understand what starts to separate out individuals in terms of their risk and their likely outcomes. So this is what prognostic factor research does, sometimes also called predictor research, where you're trying to identify variables or characteristics or biological information that can tell us which individuals are more likely to have poorer outcomes than others. And so on this particular Kaplan-Meier curve, we've just got, again, breast cancer patients categorised into 3 groups defined by grade, so tumour grade. And clearly those with the highest tumour grade have the worst prognosis. So tumour grade is a prognostic factor. So prognostic factor research aims to identify prognostic factors. Now, prediction model research is also known as prognostic model research, and here we are using multiple prognostic factors, or also known as multiple predictors, in combination to individualise our estimates of risk of future clinically relevant outcomes. So the key thing is it's an individualised risk estimate conditional on multiple values of multiple predictors for that individual. What's our aim? Well, our aim is to provide accurate predictions. These predictions are usually of risk, but they could be continuous outcomes like blood pressure or weight or things like that. We want predictions that are reliable, to therefore reliably inform patients and their families, to support clinical research, maybe, for example, for trial randomization purposes or stratification, and then crucially, of course, to allow more informed healthcare decisions at the individual level to improve individuals' outcomes, and of course by doing that to improve population outcomes as well. So we are now very much focused on individuals and getting reliable individualized estimated risks. They are produced by statistical models like penalized regression models, such as logistic regression, Cox regression, or variants of those like the lasso, elastic net. But increasingly, people are interested in machine learning methods like random forests and neural networks, a bit more black box in terms of how they get to the predictions. So perhaps the simplest model we might be thinking to use is a logistic regression model. So if we were to have a set of data which linked predictors defined by X values to outcomes, here a binary outcome, for example, mortality at 6 months, then we'd have a log odds link where the odds of the outcome, probability over 1 minus probability for that individual, is a function of an intercept which sort of maps out the overall risk in the population, and the linear predictor defined by the predictor values and beta values of the equation. So once we have that logistic regression model equation, we can then, in a new individual, we could rearrange this equation to obtain a predicted or an estimated probability of the outcome for that new individual, conditional on the parameters of the model, the alphas and the betas, plus the individual's own values of their predictors, x1, x2, x3, etc. These equations, whether they be a logistic regression type equation or a tree-based machine learning method, we don't tend to see them too much because when we use these tools, they are hidden in the background, either embedded in as a calculation in software on a web app. Here's an example of the crash prediction model tool, which is predicting poor outcomes or mortality in individuals who've had a traumatic brain injury. So you can see that you would be able to click on the web tool to put in the country, the age, the Glasgow Coma score, etc. of the individual, and then based on the characteristics of the individual, we would be then producing from the model in the background the risk of 14-day mortality, here 14%, or the risk of an unfavourable outcome at 6 months, here about 50% for this individual who's from Australia, age 47, and so forth. Now already I've been using prognostic models and prediction models sort of interchangeably. You may also know them as prognostic indices, predictive scores, risk scores, scoring systems, but a broad term really is clinical prediction models. And the aim is to estimate individualized risk. Now some wrongly jump into what they call classification, where they want to classify people as high or low, or will or won't have an outcome. And this is flawed, in my opinion, because we want to know somebody's risk of the outcome, not to classify them as having the outcome or not. So I think this is very important to mention. Also, the important facet here is that this is a multivariable situation. In prediction modelling, when we're estimating risk, and particularly when we're focusing on the future, to have a single variable that tells us everything about the future prediction prognosis is very unusual. So we're talking about multiple predictors needed, multivariable situations. Now it's multivariable, not multivariate. So with multivariable models, multivariate means multiple outcomes. Predictors, also you may know those as prognostic factors, risk factors, variables, covariates. I will probably interchange my language here, but they are characteristics of an individual that we can measure, we can record, so that tells us about future prognosis and gives us a better prediction. So things like age, BMI, smoking, increasingly genetic information, biomarkers, and so forth. Now, prediction models are very, very hot in terms of people being interested in developing them. Now, cynically, I might say that's because people want to do something quick for their CV. But trying to be more positive about the real reason is that they may want something that's directive and linked to clinical decisions. So, for example, in a venous thromboembolism, when somebody's looking at the risk of recurrence, they may want to know somebody's individualized risk of recurrence to decide whether to keep on treatment, for example, warfarin or not. And if the risk is very, very low, they may take them off that. But if the risk is, moderate or high, they might want to keep it on. So, clinical decision making. Some tools are not for clinical decision making per se, but are to give informed information about outcomes and likely outcomes to an individual patient and their caregivers and their family to understand the future. So either way, of course, we want these predictions to be reliable so that we are giving the right information or the best information that we can to that individual. I said they were a hot topic, and you can see that they have impact. These in the UK, we have something called NICE, which are a body that decides sort of which treatments and interventions and tools to recommend. And in various NICE guidelines, you can see we have prediction model tools recommended, like the Framingham score and the QRIS score, Nottingham Prognostic Index, the APGAR score, the Leicester Diabetes score, etc. So these tools are being used in practice, and they're being used to inform decision making. Like I said, the format of prediction models depends on how it was created. Now, it's very transparent and easy to provide an equation when it's based on a regression equation. So usually, if you've got a regression equation, people should be reporting that in full. And Gary Collins has often highlighted the issues that people don't tend to give even these simple equations in full. And hence why he and Carl Moons and others generated the tripod reporting guidelines. But sometimes the equation is simplified beyond a regression equation to simple scores or nomograms. And like I said, we don't always see the equation if it's based on a sort of a black box method like a random forest. Part 2, improving prediction model research. So what do we need? We need a model that's fit for the purpose. So the purpose is important to identify. Why are you developing that model? What are the risks going to be used for? And how is it going to benefit patients? We should be understanding these things before we start to develop a model. But clearly, regardless of the situation, our predicted risks from the model, or the estimated continuous values, or if it's a continuous outcome, they need to be accurate and clinically useful as far as possible. And what do we mean by accurate and reliable? Well, for me, there are 3 key things. The first one is calibration. Do the predictions that you give calibrate closely with what is observed? So if you were to try and validate your model, you would be able to observe outcomes and you'd be able to compare those outcomes with predicted outcomes. And do they calibrate with each other? Is the model helpful in that it separates out those with and without the outcomes? So are those that do have outcomes given higher risks predictions than those who don't have outcomes? This is called discrimination and measured by something like the C statistic. And then thirdly, is there clinical utility? So when I think about using this model to guide clinical decisions, so for example, if going back to that warfarin example, if somebody's risk is predicted to be above 5% and I give them treatment, is there utility in that? Is there a benefit? Is there a cost benefit? Is there a benefit in terms of the overall population, in terms of this process, this strategy of using this model to guide decisions leading to better outcomes? And we need to make sure the model is demonstrating good calibration, discrimination and clinical utility in those intended target populations where you want to apply the model to. So there's no point testing the model in situations in secondary care when it's going to be applied in primary care, for example. So calibration, these are measured by calibration plots and statistics like the calibration slope. Discrimination, measured by, like I said, the C statistic or the error into the curve. These are the same things for binary outcomes. And clinical utility is measured by things like net benefit and decision curves. And I'll come on to that a bit later because I think that's an important, often missed area. So a little bit more on calibration plots. Calibration plots are neglected in prediction model research. People usually focus on measures like the C statistic, a measure of discrimination, or the R-squared value. And I've given those 2 things here, 0.81, somebody might say, oh, that's quite good, R-squared 0.19, that seems okay maybe. But it's so difficult to understand these measures. Actually, what calibration does, it gives us a visual display of the range of predictions and crucially how they agree with observed outcomes and outcome risks. So this is what I've displayed on this right hand side here. I've got the observed probability of the outcome on the left and the estimated probability from my model on the right. And this is for a prediction model with 30-day mortality following acute myocardial infarction. Now the dotted line, the 45-degree line, is a line of perfect calibration. But what we see when we do a smooth calibration curve across all the individual points is this blue line, and we see there's some systematic miscalibration. Those at the highest risk, their estimated risks are too high compared to the observed outcomes. So for example, somebody whose predicted risk was 0.8, actually they're, in people of that type, their observed risk is about 50%. Around the bottom here, this seems to be well calibrated down here at lower risks. Now, you wouldn't know that from a calibration slope of 0.72 or a C-statistic of 0.81. So these plots are essential to provide. On the bottom here, I've got the distributions as well of risks estimated across all the individuals in my data set. So I encourage you to present calibration plots when you're doing these prediction models. Now, sadly, just going to spend some time talking about the problems now of prediction model research that I observe and the fact that you need to reduce your expectations of the quality of prediction model research in practice. And Steve McLaren, when he was the England football manager, he also said we have to reduce our expectations of the England football team. And he said that we have the players to do it. So not particularly reassuring when you're the manager of the team. But the same is true in prediction model research, that we need to reduce our expectations of the quality of most prediction model studies that we observe. And as often is the case, Doug Altman highlighted this issue back in 1995, many years before others were talking about it, that models will soon be forgotten if they are not shown to be reliable and make a difference. Now, there are hundreds, thousands, many thousands of prediction models developed each year in the medical literature. Relatively few are actually used in practice, and most, I think, are of poor quality. So we did a living review of COVID-19 prediction models, and this was published very quickly after the pandemic started. Laura Wynants and Martin van Smeden got a lot of people together across the world to help review articles that were being published at that time. And we found 232 models had been proposed within just the first 9 months of the pandemic. And our review only identified 2 of them as promising. The rest were at high risk of bias. And we concluded that the review indicates that almost all published models are poorly reported and at high risk of bias, such that their reported predicted performance is probably optimistic. How terrible is that? And it's appalling, and we should be shocked, and it shouldn't be accepted. What other issues are there? So not just in this living review, but in general, we see poor quality data sets. So people use data sets that are just in the back drawer that they can quickly get hold of, but they're never fit for purpose. So the start points and the outcomes are not measured right, or in the right place. The predictors are not measured right. So if the data set's not of good quality, we shouldn't be using it just because it's convenient. I'll come back onto this later, but if the sample size is too small, then you're going to be leading to models that are just not reliable, that they'll pick up noise and something called overfitting, where the model is just not going to be performing well in new data because your own data is picking up, when you fit the model, it's picking up chance findings. Poor handling of continuous predictors and outcomes. I'll come back onto that. Inappropriate handling of missing data. Look, most people just ignore missing data and just only look at the people that had complete data. Well, that's likely to be misrepresenting the population. Like I say, overfitting, a lack of internal validation methods. So no methods like penalisation or shrinkage to try and identify overfitting and adjust for it. Like I said, no examination of calibration is a big problem. No investigations of clinical utility. So do we know there's any benefit in using the model? and poor reporting, not adhering to the tripod guidelines. Many other things as well, which I don't have the time to go into. But these are the, in my head, some of the main things that I wanted to flag to you. Clearly, we must do better. And it's down to all of us to encourage better practice and to call out bad practice. This starts with registration and protocol publication. I feel like if we can get people to specify in advance what they're going to do and have it reviewed and critically appraised, then it's more likely to lead to a better study and certainly a more transparent study. You can publish your protocols, for example, at Diagnostic and Prognostic Research Journal, or register it at clinicaltrials.gov. Here's a paper by George Peet and myself, sort of raising the point that we need transparency and protocols and data sharing and other issues like registration in prognosis research and for prediction models. Another initiative that we've launched is a website called prognosisresearch.com. Now here on this website, we've tried to provide sort of entry-level information to some of the basics about doing prognosis research and prediction modelling. And in there you'll find talks and basics, publications to have a look at. So yeah, please have a look at that and give me any feedback if you have any to give. Thank you. It's also important to recognise different phases of prediction model research. So broadly speaking, there are three key phases. First one is model development. That's where you produce the actual model, the model equation, or developing the tree-based structure or whatever it is you're doing to produce your model. This should include internal validation. So this is the process of examining in the same data set used to develop the model, the performance of the model. That often involves resampling methods like bootstrapping or cross-validation. Sometimes people would split their data into a training data set and a test data set, but that's not really something statisticians recommend, because you're losing information in your data by splitting it out. External validation is the process of examining the performance of your model in new data. Now this may be new data from the same population that you used to develop the model in, but it may also be from a different population. It may also be at a different time, or a different place. And then lastly, it's about investigations of clinical impact. And that may be examining the performance of the model in a randomized trial where you randomized some practices to implement the model and other practices to carry on with usual care. So there's a pathway towards clinical implementation and impact on patient outcomes. And typically speaking, this is the process we go through. Now, most research that you see in the literature focuses on model development. Loads of models produced, as I've already mentioned. Much fewer on external validation. Many of the model development studies don't even include a proper or appropriate internal validation. And the impact studies, where you're examining the model as a health technology assessment, as a health technology, and assessing that technology, they are also very, very rare. And we need to improve the whole pipeline. Just going to go through some particular areas that I would recommend we all try and do better. First one is modelling continuous predictors. So I've already mentioned about continuous predictors like age, BMI, systolic blood pressure, biomarkers. They are often categorised, and in particular dichotomised. For example, age may be categorised at 65, PSA levels often categorised at 4. This may help presentation of data or tabulate data, summarise data in some sense. Some argue that it's easy to interpret, but these aspects are irrelevant. They are irrelevant when it comes to producing a reliable and accurate and higher performing clinical prediction model. For example, dichotomising reduces the power to detect genuine relationships between a continuous predictor and an outcome. If you lose information, then your model is having a lower C-statistic, for example, and is not giving a more individualized predicted risk. Rather, you're now putting people into groups, and that's what you're trying to avoid. Your whole point of doing the model is to try and individualize as far as possible risk prediction. You're also making some very bizarre assumptions, like somebody with a PSA of 3.99 is different than somebody with a PSA of 4.01, which is nonsensical and biologically irrational. So, cut points and categorization should, wherever possible, be avoided, and it's not necessary. Lovely paper by Gary Collins and Doug Altman and colleagues who, examined in simulation studies the impact of different approaches for handling continuous predictors. Very strong conclusion. They show categorizing continuous predictors is unnecessary, biologically implausible, and inefficient, and should not be used in prognostic model development. The argument back against this, and why people say, well, no, actually categorization is needed, is because clinicians and health professionals may want to group patients for decision making. But remember what I said at the start of this lecture, that we're talking about multivariable situations. So it's not just making decisions on one continuous predictor, it's actually on the value of multiple predictors in combination. And therefore, we're not making decisions based on a single predictor. We're actually making decisions based on a multivariable model. And actually, whenever we make our decisions, it's based on the predicted risk. Now, therefore, we want that to be as accurate as possible for that individual and allow it to be from anywhere between 0 and 1. We don't want to constrain it or group it. So we need to be flexible and allow for modelling continuous predictors alongside the other variables, and then make decisions on the predicted risk. And it's fine at that point to then make categorization decisions if they're clinically justified. So for example, with people who you're looking to see whether they might have a VTE recurrence, and you say, well, okay, if their risk is greater than 5%, we may do something different, like carry on with anticoagulation treatment, compared to if they're got a risk lower than 5%. So you created two groups there, but it's at the final stage based on the predicted risk, not based on a value of a continuous predictor that's one factor in a model. Another thing I would encourage you to do is go beyond calibration and discrimination and think about clinical utility. So actually, although these measures are important, a model that has high discrimination and perfect calibration may have no clinical utility, whereas the converse may be true. Andrew Vickers has made this point a lot. His quote here, specifying that a patient with cancer is at very high risk, rather than just high risk, reflects that the model is a good one, so good discrimination, but makes no clinical difference because the patient would be biopsied in both cases. By contrast, a model with only moderate discrimination might be useful if the clinical decision is a toss-up, providing just enough information to push a clinical decision one way or the other. So it really depends on the context, and it depends on where the miscalibration actually is. Here's an example of a model, and this is an external validation of a model predicting 30-day mortality in acute myocardial infarction. Here we see the calibration plot from before, and we see that, as mentioned, that there is miscalibration in the higher range. So higher risks that are predicted from the model are not as well calibrated as lower risks. The calibration slope is 0.72. So there's clear miscalibration. But the miscalibration is mainly in areas of risk about, well, maybe above 15 to 20%. And therefore, it's driven by those with the highest risk. So if your clinical decisions are actually down here, so based on thresholds around 5% or 10%, there may still be some clinical utility, and the miscalibration over here doesn't matter because you're still identifying people at high risk. So again, a reminder that, a calibration slope of 0.72 or a particular C-statistic, what does it mean? It has to always be in context. Evaluating clinical impact can be done through cost-effectiveness modelling, or like I said, through randomised trials. But these are things that sort of happen beyond your analysis data set based on either further studies or further assumptions. An alternative, which is a good way of initially examining clinical utility, is something called net benefit. Now, this weighs the benefits, for example, expected improved outcomes, against harms, worst outcomes, increased testing, side effects, costs. Essentially, what you're doing is examining the model as a test, where you're saying people above a particular value will have a particular treatment or intervention, those below it will have a different treatment or intervention, and you're balancing out the pros and the cons of that approach. So you're essentially putting benefits and harms on the same scale by specifying an exchange rate, a clinical judgment of the relative value of benefits and harms associated with using the model to determine clinical decisions. And you want to know, does our model have net benefit over other models and other strategies, such as treating everybody or not treating anyone at all? So even if the model is imperfect, miscalibrated, there may still be net benefit. Reading more about that, Andrew Vickers has published a series of articles over the years explaining and demanding really that we use net benefit and decision curve analysis, which is where we examine net benefit at each of multiple thresholds. And those thresholds are defining our exchange rate at which we're willing to implement this trade-off between benefits and harms. Formally, the net benefit can be expressed as the benefit minus the harm times the exchange rate. And the example that Vickers often gives is a diagnostic prediction model for prostate cancer. And let's say a doctor is willing to accept 9 biopsies to find one true prostate cancer, then this relates to a risk threshold of 1/9, or 11%. The exchange rate is actually on the odds scale, so that's the risk threshold over 1 minus the risk threshold. So the key aspect of this process is specifying the exchange rate. This is subjective, but clearly needs to depend on clinical judgment about levels at which are acceptable for benefits and harms, depends on many, many aspects of that clinical setting and context. Patients should be involved as well. And it shouldn't be based on what you observe, it should be based on thoughts about what the threshold should be in advance of the analysis, not based on what the analysis tells you. We can also think about net benefit in terms of true positives and false positives and sensitivity and specificity, and then work it out through that. Again, I'm just giving this briefly to guide you for further reading. Interpretation of net benefit is always very tricky, and it's something I struggle with, and many other people do struggle with as well. There's a number of papers trying to help explain it for people who do struggle with the measure. So, for example, this paper by Rusin and colleagues. Sometimes it helps to multiply the net benefit by 1,000 to give you the additional number of true cases identified per treatment without increasing the number treated unnecessarily per 1,000 individuals. Net benefit is 0 if the benefit and the harm are the same at that particular exchange rate. And the maximum value of the net benefit is the outcome proportion. Sometimes instead of presenting net benefit, we present the standardised net benefit by dividing by the outcome proportion. Just helps to give us a standardised measure on all scales. Like I said, decision curves plot net benefit over multiple thresholds, and it allows us to compare the net benefit to other models, also to treat all and to treat non-strategies. Clearly, the model with the highest net benefit is the winner, the one that does best overall. Like I say, it's wrong to use a plot like this to guide the choice of the threshold. That should be based on clinical judgment and interaction with patients and stakeholders in advance to specify what that exchange rate is in the context of the setting and clinical decision to be made. Here's an example published in the BMJ looking at decision curves of 4 prognostic models for the risk of gestational diabetes. What we've got here is that the 4 models all seem to have similar net benefit across a range of thresholds between 0 and 0.4 that were deemed to be of interest to them. The blue line is treat none, and the red dotted line is treat all. And you can see that for most of the thresholds in this range, there is a net benefit for all of these four models, and none of them seem to be much different than each other. Going back to the acute myocardial infarction model, remember we said that there was miscalibration at the higher range, but there is still net benefit. So for example, if we look at the range between thresholds of about 0.1 and 0.2, the model, denoted by this solid line, is higher than 0 and higher than the treat all dotted line. But the miscalibration later is not helping us too much, because that makes the net benefit lower than the treat none. So a more miscalibrated model will have worse clinical utility than it could have done, but still may have utility. So calibration and good discrimination is something we should always be striving for, but doesn't mean a model doesn't have clinical utility at all, in that if a model isn't well calibrated or isn't perfectly discriminative. Right, the last thing I want to talk about is my own sort of personal focus, which is on sample size and model stability. So this is based on new work that Gary and Collins and I are just in the process of publishing, and hopefully we'll see it soon. So this is stability of clinical prediction models developed using statistical or machine learning approaches. The concept here is that models that you develop are more likely to be reliable when you've used large sample sizes that are representative of the target population, that your number of predictors is appropriate relative to the sample size. So you don't want to be throwing thousands of predictors at something when you've only got 5-10 events. That your model development process tries to deal with overfitting in some way, like using a lasso or ensemble methods. And we've used appropriate internal validation methods like cross-validation and bootstrapping to examine and maybe even adjust for optimism. The converse is that your model is less likely to be reliable, i.e. it's not going to work as well in new data, when the development data is small, it doesn't represent the target population, when you're using loads of predictors relative to a small number of events. The modelling approach doesn't use methods that adjust for optimism. You don't use internal validation. And basically your whole model development process is full of noise and uncertainty, including even in situations where you are using methods like the lasso and ensemble methods, where tuning parameters are not very well estimated or defined. So this idea of an unreliable model can be expressed in something that we call instability. And instability is the idea that your model, if you were to develop it again in a data set of the same size from the same population, would end up looking very different than the one that you did develop. So if you fitting a logistic regression and you had two different data sets, let's say both of the same size 100 but sampled so that they may be different individuals, then the model would have a very different intercept, different selected predictors, different beta coefficients. If it was a random forest, you'd have different trees, different pathways, different predictors, different interactions included. All these things lead to differences. You might argue, why is that important? Well, it's important because when your model changes, it means that the predictions for an individual would change. So if predictions from your model are different to predictions from another hypothetical model, then what does that mean? So for example, if Sam had an estimated risk of 0.2 from the model you develop, but hypothetically another model that could have been developed in a different sample of the same size would have given Sam a prediction of 0.7, what's going on there? It doesn't help us. It doesn't help Sam to know that the predictions that we're giving are not very stable. Low risk maybe to high risk. So the larger the instability concern, the greater the threat a model is unreliable. Large instability means poor internal validity. So in the development population, that the model that you've developed is not likely to perform well, even in that development population, let alone in an external validation of a different population. So Gary and I recommend that we always examine and report instability after developing models, because it can expose whether a model is likely to be reliable in new data, and therefore dictates which studies should be prioritised for validation, like further validation, like in an external validation. This is not a new idea. Frank Corral has repeatedly talked about how a developed model is just an example model. Billy Stahl by Patrick Royston over the years have shown repeatedly that in small samples, different sets of predictors, different functional forms, different linear and non-linear trends are identified. And Doug Altman again leading the way back in 1989, and more recently Alexander Pate et al. Show instability of individual risk estimates, and that variability in individuals' predicted estimates are often very wide across these different hypothetical models. And we can gauge a insight into these hypothetical models by bootstrapping. So the idea of bootstrapping is that we sample a data set of the same size as our original data set using the original data set itself. So with replacement, we sample, for example, if you've got a data set of size 100, we would sample with replacement a data set of a size 100, and that becomes a bootstrap sample. We're going to then generate, let's say, 1,000 of these bootstrap samples, and at each one of them, we're going to develop a new model using exactly the same model development process that we've done before to produce 1,000 bootstrap models. Then in the original sample, we apply the model to make predictions for each individual, for each bootstrap model. Okay, so in the original sample, we're going to apply each of the 1,000 models. So for each individual, we get 1,000 predicted values, 1,000 estimated risks. We then can examine the instability across those 1,000 predicted values. For example, a prediction instability plot would plot the variability of the bootstrap model predictions on the y-axis versus the original model prediction from the original model on the x-axis. Could also think about classification instability plots, calibration instability plots, and even summarizing the mean absolute difference between the original and the bootstrap model predictions, MAPE. Let's look at an example. We're going to develop a prediction model for the risk of death by 30 days after acute myocardial infarction, following on the example that we used before. We're going to use the Gusto-1 dataset, which is freely available with many thanks to the Duke Clinical Research Institute. In the full dataset, we've got about 40,000 participants, about 3,000 deaths by 30 days. So this is a huge, huge dataset. Overall risk is about 7%. I'm going to use 8 predictors. I'm just going to force them in without any pre-processing. And I'm going to use a lasso model or a logistic regression with a lasso penalty to the full dataset. This gives a C-statistic of about 0.8. So let's have a look at the instability of this model development process. So in the full dataset with all these 40,000 participants and 3,000 events, the average mean absolute prediction error is tiny, 0.0027. And here is the prediction instability plot. This is the predicted risk from the bootstrap models against the original predicted risk. So there's, for each of these 40,000 participants, I am plotting their original risk against the range of values from the bootstrap models. And we can see that it's very, very narrow. Most of the models are giving very similar predictions. So an original model gave 0.2 for this individual. And if we look that the range of values across bootstrap models for this same individual goes from about 0.25 down to about 0.15. But the 95% range denoted by the dotted line is, very, very narrow. So there's model stability here. In contrast, let's create a very small data set, just a random sample of 500 participants from the original 40,000. Now we've got 35 events, 4 events per predictor, compared to 400 before. So now we're in a situation of small sample size. Now the average mean absolute prediction error is 0.02. Noticeably the largest is 0.14. And you can see huge instability So for example, now this individual with a predictor risk of 0.2, in some of the bootstrap models, the prediction may have been around 0.7 or even 0, and a 95% range is now between about 0.1 to about 0.4. So now an individual's instability is quite big, around 0.8. You see it goes down to about 0.2 up to about 1. So we're starting to be concerned in this situation that our model that we did develop, the original model, are those predictions going to be reliable in new data? There's strong evidence here based on the bootstrap process that that's unlikely to be the case. Interestingly, the C-statistic across those bootstrap models ranges from 0.77 to 0.83, so you might look at that and go, that's pretty stable, but it's masking instability at the individual level. What about calibration? So this is the agreement between the predicted and observed values in new data. Well, using the bootstrap process, we see that the calibration again is very, very stable across the bootstrap models when applied in the original data set. However, when the sample size is small, look at the spread of the calibration here. It's all over the place. And it's unlikely, therefore, that this model will calibrate well in new data when you've got this uncertainty. An argument that often put back to me in this situation is, well, the reason why you're seeing this is because you're using outdated methods, that, logistic regression, the lasso, things like that. We've moved on from that because we have machine learning methods, which like ensemble methods and superlearners, which generate multiple models and aggregate over them and in some sense replicate that bootstrap process. But this isn't true. If you've got small sample sizes, it doesn't matter how fancy your modelling technique is. That if you're using the data at hand and not using, say, like a Bayesian approach, bringing in extra information through strong priors, then you're going to have instability. So, for example, let's think about a random forest applied to the data sets. This method uses bagging, bootstrap aggregating to generate predictions over multiple models, includes a random element to feature predictor selection to limit the correlation across models. It might be expected to perform better and more stable than those models of lasso that I showed you before. Just focusing on the small sample size situation. So in the small sample size situation, this is the lasso model that we had before. Remember I said I was concerned about instability with a lasso. With a random forest, we see an even worse situation. Now this might be improved slightly through more careful tuning rather than using the defaults, but this is just using the defaults in this data, our forest package. And we see that, for somebody whose original model predicted a 0.8, that across the bootstrap models, the predictions could be basically between 0 and 1. So this is hugely concerning that this random forest approach is just very unstable. And many machine learning methods are unstable. They need bigger data. If you have the bigger data, they may indeed be advantageous and pick up things that you missed through traditional statistical modelling techniques. So really, I'm not trying to flag here that statistical methods or machine learning methods are better or worse than each other. That is not the debate. What I'm flagging to you is that as researchers in the prediction model field, we need to be using the right methods to answer the right research question in the context of the sample size. So if you're going to be using machine learning methods which have much more potential for complexity, they will need bigger sample sizes. And if you don't have those, then it's going to lead to more instability than traditional methods like the logistic regression, lasso, things like that. So just be careful and really think about stability and transparency going forward. Individual stability really does matter because remember, we are using a model to guide individual decision making. Okay, so you could argue that actually a model may still be useful if there's instability because overall on average we get it right, and at the population level things might improve still. Okay, so for example, the decision to give statins to those with an estimated 10-year risk of CVD above 10%, you're trying to generally across the population reduce the CVD rate, and that might still work. But surely doctors and health professionals, they're seeing right in front of them that individual patient, that face in front of them that needs their own personal care. They want to make the best decision for them, not just to treat them as somebody who, on average will get it right. So individual counselling, prioritisation of resources, personalised medicine, monitoring frequency. If different samples would lead to different models and different predictions for the same individual, then this means that the model is not great at guiding individual decision making. And is it even ethical to be using that model when you know that it's unstable, and without evidence from further validation that the model works? If you've developed a model and there's instability, that model should never be thought of in terms of being used for individual decision making when it doesn't even demonstrate stability in the model development dataset itself. There's a big push as well towards algorithmic fairness, that our models should be fair and work well for everybody. So, for example, in different ethnic groups, genders, regions, our models should be performing well and consistently well. But instability may be low for one subgroup but high for another. For example, if you've got a dataset which has an underrepresented group, then the instability may be larger. Some predictors in the model may not be measured as accurately as others. For example, if you've got one predictor with a rare category. So it's important to, when we check the performance of our models, to look at instability not just overall but also in subgroups. Here's an example going back to the lasso model. Males and females, we see these prediction and instability plots seem to be quite similar, and the average MAPE is quite similar. So there doesn't seem to be much difference in stability for males and females based on these two plots, but that may be different in other situations where some ethnic groups, it may be very unstable, but in others it isn't. A note also on explainable machine learning. There's a drive as well because of the black box nature of machine learning to say, okay, how do we go beyond this and explain what our models are doing? But I just wanted to say that if a model is unstable in predictions, then any meaningful attempt to explain the model, at the individual level particularly, is futile. So, if your model is not stable, you shouldn't be trying to explain what's going on in the model because the information's just not there. So how do we get stable models? Well, like I've said, we need a decent sample size. How do we get decent sample sizes? Well, clearly we need to recruit as many individuals to our studies as possible. But what are the minimum that we might think about? Well, we propose guidance for regression or penalised regression approaches, references at the end of these slides. And these sample size approaches target precise estimation of the overall risk. So let's make sure at least we can estimate the average risk precisely. They target a small mean absolute prediction error, and they target a small amount of overfitting. Now, I'm not going to go into the details. They're available on other YouTube talks of mine. But simply put, they require the user to input some values about assumptions about the average risk in the population, a conservative estimate for the performance of the model in terms of the C statistic or the R squared, and also how many predictors we're thinking of putting in the model. And then the PM sample size module in R and Stata, produced by Dr. Joey Ensor, allows us to quickly derive the sample size. Even adhering to this, which is the minimum, the instability may still be quite large, and machine learning methods are likely to require even much larger sample sizes than PM sample size estimates. Here's just a very quick example, a binary outcome situation. We believed in advance that the R squared would be 0.2 on the Cox-Snell scale, that the average risk in the population would be 50%. We're thinking of putting in 30 predictor parameters. So this is the code for PM sample size, and there's 3 criteria that it examines, and the largest sample size from these 3 criteria gives us a sample size needed of about 1,200 in this particular example, so about 600 events, about 20 events per variable per predictor parameter. If the model performance is expected to be larger because previous models of this type had a larger R squared, then the sample size would come down, because clearly the more variation you explain, the less noise there is and the more stable the model would be. So that's just a pointer towards the PM sample size option. Even at the minimum sample size, though, there's still instability. So these graphs are at the minimum sample size. For the Gusto example, 53 events, 7 predictors. So an events per predicted parameter of about 7. And the prediction instability plot, the calibration instability plot, are still quite big, aren't they? So, you could strongly argue that even larger sample sizes are really needed here. But this would be the bare minimum that I would think about. So in summary, I really hope this has been useful. There are so many different topic areas here that I could talk about. I've tried to pick out a few that I think are the ones we can address the most. Things like protocols, things like getting our sample size right, analysing continuous variables right, checking the stability of a model after it's been developed. Sadly, most people don't do any of these things, so current standards are very poor and most models are never used, and indeed never should be used in healthcare because they're not fit for purpose. But let's do better. Let's really encourage ourselves and our colleagues not to be developing models on a whim. Make sure there's a clinical rationale, there's a need for it, that we understand what's already out there in the literature, that we validate those models first, that we understand whether a new model is developed, and then go forward and, do the right things the best we can with the largest sample sizes and examine clinical utility and stability and aspects like that. I'll just leave you with a few references. Again, like I mentioned, check out prognosisresearch.com. We do run a number of courses in Birmingham online if you're interested in risk prediction and prognostic models, and also in IPD meta-analysis. And these are our sample size papers, and also that one at the top is the one that's coming out, we hope soon, about instability. Thank you so much for listening, and I hope this has been helpful.